Check and make sure it's up and running. Yeah, perfect. So welcome back. We do have an exciting show for you guys today. Lots of interesting topics to go over, tons of articles, and hopefully that'll be really exciting for everybody to watch. And hopefully you'll have lots of questions as well. So yes, I can definitely hear myself over there. Good. So we'll just let everybody sign back on. Sorry for the problem with the volume initially. I don't think my mic was on. So we've got it working now and everything should run smoothly. So we'll just give everybody a second to come on. Some interesting new developments while we're waiting, and I'll repeat this several times through the show. We now have our sign up on the website. When you go on our website, if you pause there long enough, you'll see something that says a petition or a sign up for a petition, and that's to get funding for our Windsor program. So from anyone from our region, Sarnia, Leamington, Essex, Amherstburg, LaSalle, Windsor, Chatham, even out to London or Toronto. We are more than happy to get your support to get a funding program here in Windsor. So make sure you sign up for that and blow that up. Send it to your friends, send it to your family. The more pressure we get from people who are in this community or even outside communities, we can send that to the government, and that will really boost our chances of getting the funding. And hopefully we can do something good with that and access the resources we need so we can help everybody out there and not make it just about people who can afford it. So we are super excited about that. So make sure you sign up, and it doesn't matter if it's male, female, young, old. Everybody should get on there and sign up. The more people we have, the more beneficial it will be as a petition. And as you can well imagine, we need thousands and thousands of people on there. So please help spread the word, get as many people as you can to go on that and add to it and put their names in and sign up. So that would be really helpful. And we'll briefly start talking about what inspired this week. This week was inspired by a young lady that reached out to me through Instagram just over the weekend, quite desperate to get better information because the fertility center she was working with really couldn't help her in the way that she wanted. And she had gone through several cycles of monitoring with ovulation triggers during the monitoring. So this is someone that was making eggs on their own. They weren't PCOS or anything, but they were now being monitored, and then they were being triggered for the ovulation, and they weren't getting pregnant, and they were wondering why. And so I thought, that's kind of interesting because my knowledge of that topic is fairly reasonable, and I had a very different opinion from what she was doing. So I thought, this would be a great fact or fiction. Let's talk about a few different elements of just kind of natural monitoring, natural fertility, triggering your natural cycle versus not triggering, whether insemination really helps, and when you're adding it to simple things like PCOS and so on. So a whole bunch of topics kind of crammed into one, and kind of reaching a bit of a broader audience because, we know that the focus is frequently on IVF, but it doesn't have to be always on IVF. We can talk about the patients going through insemination, which is actually a larger proportion of you guys. We have a relatively small proportion that are doing IVF and a larger proportion that are doing insemination or IUI. So that was where the topic came from. And so I'll get right into it. So the first one I want to look at is that very topic of whether or not spontaneous triggering of your ovulation, meaning your LH surges, you get a natural boost of the hormone that tells your ovary to release the egg, and then the egg gets released from the ovary by natural means versus actually taking the HCG trigger shot makes a difference. So is it better for us as fertility specialists to monitor your cycle, see where your cycle is going to, and then give you a booster shot of HCG at the time that we think it's optimal, or should we just let your body do what it's naturally going to do and then do the insemination? So the first article is actually a few years old. It's from 2012. It's from a fantastic author who's done a lot of amazing research projects in the infertility world. His last name is Kolobianakis. It's a Greek group, and the lead author is Kairu. And they actually have an American author in there as well, Paul DeVroy, who's a very well-known American fertility specialist also. So very interesting study. They had about 300 patients altogether who were undergoing insemination cycles. And they wanted to look at this and see if letting the patient naturally trigger, meaning their LH surge occurred, like I said earlier, versus monitoring them and then using the injection to help them trigger made a difference. So they split them into two groups. So the first group was basically the group that was being just monitored with an ovulation kit. So these are the kits where you pee on a stick and then it tells you when your ovulation is going to occur. And the second group was the group where they gave them HCG. What's interesting about this study? This study is pretty cool. They did what's called a randomized controlled trial, and randomized controlled trials in the infertility world are very few and far between. Essentially, what you're doing is getting someone to sign up and agree that without knowing ahead of time which group they're going to be in, they're willing to randomly be assigned to one group or another. And then when they're assigned to that group, they then have to follow through with whatever is prescribed for that group. And that way you eliminate a lot of the biases that can go into research studies where, people think this treatment is better than that treatment, so they all want to go into that treatment. So, or this treatment. So basically it's a very well done, rigorously controlled study. It eliminates a lot of the biases. And so you get really robust data from this. And the randomized controlled trial is the holy grail of research for everyone doing any kind of procedural or medical pharmaceutical type trial. So basically 150 patients got the HCG shot because they were being monitored. They did ultrasounds on day 6 and thereafter as necessary. They monitored the hormones. And when they got to this time where the size of the follicle was greater than 17 millimeters, they triggered the release with the HCG shot. And the other group, they just followed them with those urinary LH kits. When they hit a surge, they went ahead the next day and they did their insemination. So both groups were getting insemination. The first group was being monitored. Then they got the trigger shot. And then they went ahead and did the insemination 36 hours later. The second group just had the ovulation monitoring with the urine. And then when they had the spontaneous surge, they actually went ahead and did the insemination 24 hours later, which is pretty standard for all of us. When we trigger you here, we're going to give you a 36-hour window. And when you spontaneously trigger, because we're not quite sure about when it's occurring, we actually give you a 24-hour window. They have done studies comparing insemination for patients with 24, 36, and 48 hours. And there is no difference between 24 and 36. It's a little bit less when you do 48. Okay, so what did they show? They showed that the ongoing pregnancy rate, so these are fetal heartbeats in a pregnancy, so they're actually seeing live fetuses in there, was almost half when you took the HCG shot than it was when you spontaneously triggered. So if I monitor you and then I decide, hey, her follicle to me looks like it's at the right size, 17, 18 millimeters, and I tell you, hey, run home and do your HCG trigger, that actually is going to reduce your chances of success compared to us just leaving you alone and letting you ovulate naturally, where you get a much higher success rate. How much is the difference? It's actually huge. 10.7% pregnancy rate when you did the HCG trigger and 22.7% when you naturally released your egg with doing insemination. That is a very, very substantial difference. Why was this important to me? Because this patient was really getting the wrong treatment at the center she was at. They were bringing her in. She wasn't even doing insemination, but it's the same idea. They were bringing her in. They were monitoring her and then saying, oh, your egg looks ready. You should take your trigger shot now. But I knew from having presented this data a long time ago that that actually cuts your chances in half. So we should not be triggering you in the majority of cases when you are just naturally ovulating or naturally going through your cycle. It is a very, very little benefit to you, and it may be detrimental based on this data. So typically for us, a lot of people say, well, why aren't they monitoring me? And why am I just using the ovulation kit? So as long as you're regular, you're ovulatory on your own, us monitoring you helps me bill OHIP, but it doesn't help you in any way. In fact, it's detrimental to you. So we don't do it because I only want what's best for you guys. So we do what's best for you guys. So getting monitored, getting triggered in a natural cycle when you're already making your eggs routinely is not helpful to you. And there's actually other data that suggests the same thing. Even if you're taking Clomid or you're taking letrozole, you can also naturally, spontaneously release, and that's still okay as well. So when you're going to be naturally monitored and you already are ovulatory, it is a fiction that an HCG trigger is helpful. It is actually detrimental to you. It cuts your chances in half. You should naturally surge and not have to try and be monitored and go through all that torture. So what about in the other populations where you're doing donor insemination? So this is a more recent study from 2017, from a French group in Montreal. And they looked at timing therapeutic donor inseminations in natural cycles. Again, whether they should do HCG or urinary LH monitoring. And what they showed was there was actually absolutely no difference whatsoever. And they said that LH monitoring, urinary LH monitoring, is as effective as ultrasound monitoring and ovulation trigger with HCG in the therapeutic donor insemination. So even if you're using donor, there is no benefit to us doing all the monitoring. Well, some people might say, well, is there a disadvantage? There is a disadvantage. You got to come for a bunch of visits. We got to keep poking and prodding you with the ultrasound. I don't know of too many people that come in here saying, oh, please let me do another transvaginal ultrasound. So there's the blood draws, there's the ultrasounds, there's all the poking and prodding. And in this day and age where we have to pause between patients, we got to clean the room, everybody's wearing a mask, you got to go through all the crazy screening, we have to point that infrared thermometer at your head and fire the little trigger there. I feel like we're shooting people every time we do that. It's probably detrimental. We're increasing your exposure. You can literally stay at home, pee on a stick, which could not be any easier, and end up with the exact same result. It makes no difference. So in this study, they weren't saying it was detrimental, but they were saying it wasn't beneficial to do the HCG triggers. So considering there are some side effects to having to do it with all the monitoring, it's still probably on balance not particularly helpful for you. So again, is it a fact or a fiction that you need HCG to trigger in a natural cycle when doing insemination? It is a fiction. You do not need to get the HCG trigger if you're already ovulatory. It is not helping you guys. So why is this important for me? Because in Ontario, we do get paid to monitor you by the government if you're just going home to have intercourse. Insemination's a different story. But the outcome of this is still the same. Whether you're getting the sperm from an INSEM or you're doing it naturally, it's going to give you the same exact outcome in terms of the data and the results. So there are loads of centers that keep bringing the patients back month after month for more natural cycle monitoring. We do monitor everybody for one natural cycle. I need to map out your cycle so I get to know your physiology and I get to know what's going on with you. That is important. But is it important to bring you back 3, 4, 5 months in a row? No, it's ridiculous. It's doing absolutely nothing for you except making you late for work, aggravating you, and wasting your time. It does not help you when we do that, and definitely doesn't help you when you now add in the cost and the pain of having to do HCG shots. So don't do that. If your center is saying come back for several months of natural cycle monitoring, the only reason you should ever do it more than once is if there was something really confusing, they saw a cyst, you didn't make an egg at the right time, or it took a really long time, it was an unusual cycle for you, okay, that's justified, come back for one more. But if it's just, hey, we're going to run you through the grinder and just keep bringing you back for the same thing over and over again, useless. Don't do it. It's just really good at making us wealthy and really not good at helping you achieve your goals here. So that is not helpful for you guys. So again, that is a fiction. Okay, what about when you're adding in PCOS? Because people always say, well, wait a minute, you're talking about ovulatory women. What about the anovulatory women? Does it help doing it with intrauterine insemination with timed intercourse when you're using clomiphene for PCOS, and then again, letrozole as well. So in this particular instance, this is kind of interesting. When they looked at this group, what they said was, if you're going to do insemination after taking Clomid, is it beneficial to take the insemination, or is it beneficial to just do intercourse? So in other words, if you're going to take Clomid and you're going to go home and have sex, so now you don't need us, we're just sending you home to have intercourse, is that better, or should we add in the insemination to improve your success rate? So this is no longer just a monitoring issue. You can still monitor with the LH kit, but what should you do once you are positive with the monitor? Should you just go home and have intercourse, or is it better to do insemination? So the interesting thing here was that it's a fairly small study, 147 cycles, and they had 56 with insemination and 91 where they just went home and had timed intercourse, where we told you, hey, this looks like it's the right time, go home and have intercourse. And when they looked at these two groups, what they actually showed was that in the group that was doing the insemination, the rate was much higher for clinical pregnancy, 48.2% versus just 11% in the group that went home and had intercourse. So even if you have normal male parameters, your chances of success when you're taking a pill like letrozole or like Clomid, and you have polycystic ovarian syndrome, are higher when you add in the insemination. The same thing is critically true for those of you who have unexplained infertility, and we go through this almost every week on the show. If you have unexplained infertility, the pills alone and intercourse are not helpful. Insemination alone is not helpful, but the pills with insemination, as they did in this study, are definitely helpful, and it makes a huge difference. So is insemination beneficial when you are trying with polycystic ovarian syndrome versus just timed intercourse? Yes, the insemination is actually beneficial. So timed intercourse is not helpful for you. That's where we're doing the HCG trigger and telling you, hey, go home and have sex in 36 hours. It's actually better for you to do the intrauterine insemination. So again, another fiction. It is fiction that doing the timed intercourse is helpful. You are much better off doing an insemination. The last study I wanted to take a look at, and I got to actually load up another laptop here for it, is from the Cochrane database. So the Cochrane database is this huge database where they do these sort of mega meta-analyses, and they review very, very large topics very rigorously. And in the Cochrane database, they were actually analyzing the various ways that you could actually sort of watch someone in terms of natural cycle monitoring. So whether it was HCG trigger, whether it was temperature monitoring, whether it was a urinary monitor, and so on. So the last update to this is kind of old now. And I apologize on behalf of Cochrane for that, but I'm not a member of the Cochrane team. And so what they showed in that was that there was quite a large number of studies that were available to review. And when they whittled it down to the small amount that was left over, and that definitely always comes down. So they start off with like 900 cycles, and then by the time they get down to the actual studies that they say are good, they're down to 18 in this one. So from the 900 down to 18, they ended up with 18 good studies, and they said at the end of it, there is insufficient evidence to determine whether there is any difference in the safety and effectiveness between any of the different methods of synchronization of ovulation and insemination. So there is probably no difference between any of these different techniques, which means simpler is definitely better and less, sort of difficult for you guys having to bring you and take you and all of that stuff. As well, it's definitely going to be cost effective because you don't have to pay for all the meds and all the drugs and lost time from work and babysitter for the other children and so on. So the simpler we can keep it, the better it would be for you guys. And so that's really the mode that you want to go with, which is why that's what we've done for years now, both in our Sarnia location and in our Windsor location. When we give you letrozole or Clomid, we send you home and say, just wait for your ovulation surge. Now, it's true that once you surge, you also want the trigger shot, but that's with your natural surge, which is very different from us monitoring you and making you surge. So that was from our Fact or Fiction a couple of weeks ago, where it showed that if you add in the HCG shot with your natural surge, that's actually beneficial. But making you surge because we think your egg is ready is actually not correct. Your body probably knows way better when it's supposed to release its egg than we can with blood tests and ultrasounds. So that is the factor fiction for this week, or factor fictions, I guess. This was a plural this week. So we tried to bring in a couple of different topics for you guys to have exposure to. And I wanted to make sure you guys all knew about these, because this poor soul who reached out to me said, I wasted 5-6 months doing all these these monitored cycles, and then I skipped my spontaneous ovulation and made myself ovulate, and that's just not the right thing to do, guys. So you don't need that for your natural cycle unless you're not ovulating even with medication like letrozole. Now, I do want to send out a big warning, because everybody's going to go to their fertility specialist tomorrow and say, why did you do this and so on. So keep in mind, they do need to know what's going on with your cycle if you're not regular. In some instances, even after you've taken medication, you're not ovulating regularly. So we need to know that you have, and the only way to know that sometimes is to monitor you, because some people you can't tell with the labs. And then the last thing that's really important for you is to remember that if you're doing injectable medications, so the Gonal-F and the Menopur and the stuff like that, it is definitely really, really important for you to make sure that you absolutely are being monitored. You cannot just take shots of Gonal-F and Menopur and decide that you are going to actually end up being okay without monitoring, because that is going to very rapidly turn you into Octomom. And I don't want to be on my own TV show because I created 8 babies in one lady. So definitely do not do that. You have to be monitored when you're taking the shots. It's critical. So there are exceptions. This is not a one size fits all or a one shoe fits all scenario, but you do need to be cautious, and definitely don't go back for months of natural cycle monitoring at any clinic, because that's just totally a waste of your time. Okay, so I want to make sure that you guys like, subscribe, and comment on the video. We are super excited to do these for you. It is very important that we make sure that you get the feedback to us, and that we get the likes and the subscriptions so that we can help this expand and get it to more people. So thank you for watching that part of the show. And we're going to take questions now. So I guess I'll start with the ones that people wrote in. It says the movie recording has stopped.
Okay, no problem.
Yeah, go for it.
Is the adoption of embryos a long process, and is it costly?
So embryo adoption, is it a long process and costly? Well, there are 2 ways to do it, and I can go through the costs with you. So if you use an agency, I personally think it's prohibitively expensive. And it can be very, very high in terms of its cost. So 13 to 15,000 if you're using an agency. And I think that's just maniacal. I don't think that that's appropriate. So we definitely do not recommend using the agencies when you are trying to access donor embryo. When you are using it just directly through a fertility center, and we actually had a reasonably robust program at my previous fertility center and certainly hope to have one again, then it's actually very cost effective. We basically only charged people for the embryo transfer and how long the embryos were stored with us. Now, obviously, the longer the embryos are with us, the higher those storage fees go. So it can get pricey, but we generally kept the price just down to around $2,500, $3,000. So that was a really great option for a lot of patients. The one issue you all got to realize about embryo adoption, and no one's asked us this on Fertility Fact or Fiction before, so it's a great question, is that we can't always get people to donate their embryos. And that hopefully is understandable for all of you. Obviously, it's a hugely precious gift to give, and not everybody's comfortable with giving that gift. So many patients will say, no one else can have my embryos. I'm not okay with third-party donation, in which case we can't use them. But if there are embryos available, I am absolutely the first person to jump on the opportunity to donate them to someone, because the last thing I ever want to do is destroy valuable and totally healthy, viable embryos. So yes, it can be cost effective. It can also be frighteningly expensive if you go through an agency. My recommendation, go directly to the centers. Do not go through an agency.
might have missed this from a previous show. Did you get the okay to do embryo transfers yet?
Yeah, embryo transfers don't really need an okay. We're just in the final stages from the college, but that embryo transfer part is okay. And for those of you that have been asking, we have started the process. My embryologist was actually at the Nahal Fertility Program today. I think we've resolved some of the outstanding issues that we had in order to get them sent over. Nahal has been really accommodating and helpful in trying to get the embryos over and showing our staff how to process the embryos that they've frozen. So we're really looking forward to getting those embryos moved for our patients that want to move them to us or to create in Toronto. And we'll be ready to help you soon. We did secure both package and individual pricing for sending loads of embryos at a time. The lab director at the Nahal Fertility Program feels that that's not in the best interests of patients because there are safety concerns with it. So we are going to be doing them individually. It is a tiny bit more expensive, but if it's safer that way, that's probably what we should be doing. And so we want to do what's best for everybody. And so we're going to run through it that way. So yes, we are starting to move the embryos. We are putting everyone in touch with the company called Core Cryo, Corecryo. The gentleman that you want is Patrick Storr, and he will make the arrangements to ship your embryos. There is some paperwork you got to fill out, and we need to make sure everybody's sexually transmitted disease screen is up to date. But aside from that, we are ready to go and happy to take care of it.
Next question is, here it is. Mercier therapy has been suggested to me.
Yeah.
Thoughts, pros, cons? Thanks, Lai.
Sure. Mercier therapy is this super deep massage into your ovaries. So apparently the theory is that if you press hard enough on a woman's abdomen, you can somehow improve the blood flow to the ovaries, and that this helps patients who have diminished ovarian reserve, poor egg production, and so on. So there are no studies. Let me start with that. There are some anecdotal reports, and I actually spent a good part of last year speaking to a lady who was in Sweden who provides this and was actually willing to come out. The cost was insane. It was $3,000 for the therapy plus her airfare to come and do it. The idea behind it, to me personally, makes zero sense. There is no way I could put enough pressure on your abdomen to even influence what's happening on your ovaries unless I'm either reefing on you to the point where by all justifiable means you should be screaming, or I am pressing on someone that is paper thin, and so I can actually get to the ovary, in which case, again, it's going to hurt like hell. So the idea that we would somehow manipulate your ovary is really not logical. Even doing pelvic examinations to feel the ovaries was actually something that the American College of Obstetricians and Gynecologists said basically should be abandoned unless you're feeling for a tumor, because in normal healthy ovaries, you can barely feel them. Even when you're really good at this, like we are, and we're trained to do it, it's still difficult to feel them sometimes. So the idea that someone's going to massage blood flow into your ovary, to me, it just doesn't make any sense. So I'm a huge skeptic of that. If there was data for it, I'd maybe say yes. That's what we do with this show. We bring out the stuff that has data for it. There is nothing on the Mercier technique. And so I would say hard no for me. That is definitely a fiction. You can throw up another fiction there. It is a fiction. There's no data for it yet. So it's very expensive. It's probably quite painful. It doesn't make sense. If you're looking for something like that, acupuncture actually has demonstrable blood flow changes. So you can actually do acupuncture on someone and before and after put an ultrasound in there and watch the blood flow to their ovary, and it'll change on the ultrasound. Like, you can measure the difference. So if you're going to do something like that, rather than have some creepy person poking around your insides, just do acupuncture. And then you can have a nice person poke around your outsides.
Relation, very tender breast from ovulation to cycle and fertility hormone imbalance.
Yeah, that's really tough to answer. So is the tenderness of your breasts related to your hormone production? It certainly can be, but it's so hard to say because some women's breast tissue is different. The receptors for estrogen and progesterone will be different. The concentrations will be different. And then your sensitivity will be different too. Let me do some Facebook questions. We don't want to keep them all waiting too. If a woman is pregnant and falls, should she always go to the ER? Is it always an emergency? No. If there is no abdominal trauma, you have no bleeding, no leaking, and no cramping, we actually are not going to do anything for you in the ER. If you've hit your abdomen, we need to watch you. So unless it's a bad fall, something's bruised, damaged, you've actually had contact with your abdomen, or you're cramping, bleeding, the baby is not moving as much if you're far enough along into the pregnancy, you have spotting and your blood type is negative, there was just some other kind of concern, it was a hard fall or a car accident, seatbelt tightened on your belly, something like that. Yes, there are circumstances where you should go get checked out. But as a general rule, if none of those significant factors apply, you don't need to worry about it. It's not important. That's not a weird question, by the way. That's a huge part of what we deal with on a daily basis in OB triage. If I look tired, it's because I was up all night delivering babies again last night. Do I mean to have IVF here? We already have IVF here. So embryos have started arriving. And one of my favorite couples sent their embryos all the way from Florida to here. So congratulations, ladies. You were one of our first. And we have all the equipment. Everything is ready to go. We just need permission to get started. I know the Sarnia clinic just opened for monitoring. Are they open for IUI now too? Yes, Sarnia is open. So we are ready to go in Sarnia. God bless Carrie, Tara, Lori, and James, who are all up there working. And then we have our ultrasound folks as well, Janelle and Azza. So thank you, everybody, for your amazing team effort. And now we have a pharmacy link up there as well. So Kareem Rageb is helping us also. And we've got an amazing team up there to help us with getting Sarnia back up and running again so we can help the patients out there.
What is the difference between excision surgery and cauterizing burning endo?
Oh, wow. Okay. So this one is super controversial. So there is a school of thought that says that you must always take out the endometriotic lesions versus just burning them. And the idea behind this is that if you don't remove them, it's always going to come back. So that is not true at all. I actually had I felt terrible. It's one of the few times in my career I really felt terrible about a case. I had a young lady that came in here adamant that I had to operate on her for like the second or third or fourth time. I can't even remember now. Multiple surgeries previously. Who was adamant that I go back in there to take out more endo. Well, you got to understand that no matter how good the surgeon is, the chances that you're going to actually end up with an injury inevitably from having multiple surgeries is high. There's the anesthesia, there's bleeding risk, infection risk, and injury risk. And this is not necessarily a totally benign surgery. Underneath that stuff we're burning or removing are structures, your ureters, your blood vessels, your nerves, your bowel, your bladder, the ovaries, the tubes, the uterus, and so on. So you do not necessarily want to have multiple surgeries done because the risks start to go up. Scarring, adhesion formation, more pain, more infertility. And depending on what actually causes endo, and no one knows what causes endo, the reality is that if we burn something or remove it, we've now created an area of scar. And that scar is sticky and more endo can go and stick there. So it's not necessarily always a great idea to just keep operating. The recurrence rate is 30%. 30% of patients will need more surgery even after they've had surgery. So the answer to your question is they've actually compared this in a very large study, and there was a 1-point difference in a 100-point scale in your pain scores between excision and ablation, where we just burn it, which is clinically meaningless. So on a 100-point scale, a 1-point drop is totally meaningless. So no, there is no difference between excision and doing ablation. And if you watch our endo video, either the long video on YouTube or the little one we have on Instagram, and then I think we broke it up again on YouTube as well, right? So the YouTube video is now little packages as well as a longer video. You'll see me doing surgery on endo, and that's all me doing the surgery. So I excise sometimes when it's appropriate, and I cauterize sometimes when it's appropriate. You got to pick and choose. Again, I always say medicine is not cookie cutter. It's not like one size fits all, or it's one thing for everybody. So it's definitely important to get the right therapy. Nowhere is that more important than in surgery, where you need someone who is looking at the whole picture from the standpoint of a fertility specialist. I actually feel like the fact that fertility specialists have moved away from doing their own surgery and kind of farm out the surgery to laparoscopists and minimally invasive gynecologists and then just do IVF is actually a terrible idea. You're never more acutely aware of what's important in the surgery than if you're the one that's got to do the IVF subsequently. So I love doing all of that stuff myself.
I started baby aspirin and ending up having a hematoma in my womb. Unfortunately, I miscarried. Would you recommend it again?
So it's tough to answer that question without knowing your full history. Aspirin itself does not cause miscarriages. In fact, there's pretty good evidence that it likely reduces miscarriages. So it's not necessarily correlated with the fact that you had the bleed and then the miscarriage. About 25% of women will bleed during their pregnancy, and not all of them miscarry. In fact, very few of them go on to miscarry. So it is reasonable to consider it again, but it depends on your history. I would need to know more about the reason you were on aspirin. When did the bleed occur? Was there a traumatic event? Are there other things about your uterus or your history that are important?
I finished my cycle monitoring on April 28th. How long do I expect before I get my appointment with you to get results and ultimately make a plan?
So the one and only benefit to coronavirus, aside from the fact that my family is home with me and I get to see my amazing kids home with us all the time, is that we're actually almost completely caught up now. So pretty quickly we'll be getting back to people. Consults were basically caught up. And getting back to you for what we internally call our I1, which is your first infertility follow-up appointment, is usually happening within about a month of the time you're finished everything. So it's pretty quick. We should be getting back to you. Let me do some from here. This is the doctor I was telling you about. I donated to his clinic. Oh, best doc ever, hands down. Well, thank you. That's very sweet of you. Hi, Dr. Victory. Sorry, but I'm supposed to do dual trigger tonight for my IUI on Wednesday with you guys, and I'm ovulatory. Should I not do the triggers? No, do the triggers. It helps. So if you're ovulating naturally and you are triggering, it actually significantly increases your success. That was a study from McMaster University and the One Fertility program, some of our friends out there. And they published that a few years ago. And we actually had it on the Fact or Fiction a couple of weeks ago, maybe about a month ago now. That was back when we were at the other place, right? At the table. Place. Maybe more than a month ago. It was in a different part of our clinic. So yeah, definitely trigger. And double trigger seems to be better than single trigger. So double trigger. What's the average cost for FSH injections without coverage? So that's a great question, but it's super hard to answer because the amount of FSH injections that you need mainly depend on your age, then your ovarian reserve, and then your weight, and then of course what you're doing. So if we're just aiming for 2 or 3 eggs, I usually tell patients a minimum of around 1,500, 1,000 to 1,500. But if you're trying to do 20 eggs with IVF and you're, let's say, 37, 38, you could spend $5,000, $6,000 on meds easily. So it depends on your age, your body mass index, how strong your ovaries are, and what we're trying to do with the shots. Dr. Vickery, when you discuss your success rates, do you mean live birth rate or chemical pregnancy per cycle? Live birth rate is usually what we're referring to when we're talking about success rates, but when we're doing the fact or fiction, I'll usually tell you which one it is based on whatever the study result was. One more. Is IUI still the right path for us if I'm PCO but ovulate on my own? You've put me on letrozole to make sure it's happening every month regularly, just making sure we're on the right path. Well, it's certainly reasonable to try on your own, but as I mentioned, if you are PCO, not ovulatory PCO, but anovulatory PCO, where you're not regularly ovulating, and you're taking a letrozole or a Clomid, the success rate is higher when you add in the insemination. Now, is it mandatory? No. And if the sperm is normal, you're certainly welcome to try on your own. You will get a success rate, and it's a reasonable success rate. But if you want a higher success rate, you need to throw in the insemination to get the added benefit. Yeah.
I picked up, where'd it go? Someone liked the post and I went to the top. I picked up my melatonin. Could you let us know why and how it is good for fertility? Thanks.
So I don't know that they necessarily know why, but we did do a fertility factor fiction on it. That was a few months ago.
That's for sure on that side.
That was like on January, yeah. So back, I think around January, February, we did one on melatonin, and you can watch that show on YouTube. It is there. But essentially, it does have some hormonal manipulation, and they believe it has some anti-inflammatory properties. It definitely helps you sleep better. We know that about melatonin. And if you're sleeping better, managing your circadian rhythms, which is part of your metabolic sort of balance within your body and your hormonal balance within your body, can actually improve your overall hormonal performance and balance and metabolism. So when you've got the hormones kind of doing their natural rhythm and